Yes, once again, in case there's anyone who is watching who has not been watching for the last few days, that's Council, Ms. Richards and myself, are in Fleetbank House, a large room, largely empty, with three members of the legal team, three members rather of the inquiry staff, including Mary, who does the swearing in, and Shumik, who his job is to make sure we all see the right document at the right time. You, Professor, I imagine are still at home.
I am, sir.
And your solicitor and counsel are elsewhere, as are other counsel for other recognised legal representatives. Thank you very much. We have, I think, about 100-odd people watching again, Professor, so that's who you're talking to as well as directly to us.
Professor Lowe, I want to ask you next about testing for hepatitis C and the arrangements that were made at the Glasgow Royal Infirmary in that respect. I want to look first with you at 2 minutes of meetings and then ask you to tell us about the process. The first minute, Seamus, is HCDO 40-271_014. We go to the second page. We will see these are minutes of a meeting of the AIDS group of Haemophilia Centre directors on the 12th of February 1990, at which you were present. Now, we'll come back to this document later for other reasons, but if we could go to the 5th page, please, Seamus. And if we could zoom in on the top paragraph, so the first half of the page. If we pick it up for present purposes, where it says Dr. Lowe thought, so 6 lines down, Dr. Lowe thought there was a difference between testing LFTs and testing for hepatitis C, and he wondered whether the patient's consent to testing should be sought. Dr. Mortimer said he thought that reliable hepatitis C tests would be available in about a year. At the moment, the tests were quite reliable, but it would soon be possible to do confirmatory tests. Professor Bloom didn't see why permission needed to be asked for hepatitis C tests, as this was just another LFT. Dr. Savage said that patients were now becoming more and more conscious of what tests were, so he would advise caution at present. Now, I'm just going to look at one other meeting that took place very soon after that and then ask you about it, Professor. So that was 12th of February, and then if we go to PRSC 40999, please, Seamus. We can see this is a meeting on the 26th of February 1990 of Haemophilia Directors for Scotland and Northern Ireland, which was chaired by you. And if we go to the second page, please. And we look at the bottom paragraph, paragraph 6. Hepatitis C tests. At a recent meeting of the Regional Haemophilia Centre Directors AIDS Committee, a representative of the Medical Defence Organisation was quoted as considering that hepatitis C testing could be undertaken on the same basis as other LFTs, i.e. HIV-type counselling was not necessary. Now, against the background of those 2 meetings in February, Professor Lowe, can you tell us what you meant, if it's an accurate record of what you said at the first meeting, by saying you wondered if consent should be sought?
Yes, I wanted to raise the issue because I don't think the UK HCDO had considered it before. And as you can see from minutes, I think some people thought, well, it's just another liver function test. And I thought, well, not really. It's probably the same as hepatitis B, where once you do get a test, you want to think what you say, for example, to patients when you're testing them for hepatitis B. And at at that meeting was, I think, a Dr. Ian Simpson, and he was from the Medical and Dental Defence Union of Scotland, of which most Scottish-trained haemophilia directors in Scotland belonged, including myself. So he, I think, was advising on various matters, but I did ask him at that meeting, I think following that discussion, I said, right, I'm the only Scottish Haemophilia Centre director here, and we're having a meeting shortly of the Scottish Haemophilia Centre directors, and it would be useful if you could clarify what you think should be the consent process for hepatitis C. And I think to summarize our discussion, he said, well, what do you do routinely already? So I said, well, we do liver function tests, it is routine, and we routinely test for hepatitis B. We've been doing that since the 1970s, and that's monitoring the patients. And he said, well, what do you say to them? And I said, well, routinely at annual reviews, we say we're testing for hepatitis, we're doing liver function tests, we're doing hepatitis B. So what should we say when there's a hepatitis C test available on the NHS? And he said, well, I would consider that on the same basis. You would say, we're testing you for hepatitis B for years, and now there's a new virus discovered, hepatitis C, and we now want to test for this because it's extending the monitoring that we're doing of you for hepatitis. And I think the concern at the time generally was, as you know, in the late 1980s, that you needed detailed counselling before doing AIDS testing, HIV testing. And I said, so we don't need to do HIV-type counselling. And he said, no, this is routine hepatitis testing. And that, I think, was the information I conveyed to my colleagues at this meeting, of which you have the minutes, of the Scottish Haemophilia Centre directors.
Why was it a decision for Dr. Simpson of the MDD-US? Wasn't the question of the most appropriate clinical course to take in the interests of patients a matter for your judgment and the judgment of your colleagues?
Well, yes, indeed, and that's why I was raising it for discussion at the UK HCDO, and then, of course, at our Scottish meeting. And I think I did say this is the MDD-US representative, but I think he attended UK HCDO meetings on behalf of all three of the UK medical defence societies. And in Scotland, certainly his organisation would be the one that we should contact about questions of information given to patients. And I think I did say, I recognise that some of my colleagues may belong to other defence organisations, and you should maybe check with them. So I think we're all of the same mind in Scotland that that's fine. When we're talking to patients about hepatitis C testing, we would undertake it on the same basis that you didn't need HIV type counselling. You just considered it as you would when you were talking about testing for hepatitis B.
Did it occur to you and your colleagues, or was there any discussion about, irrespective of what the legal requirements might be, that it might be the right thing, a desirable thing, to do some form of equivalent to HIV testing in relation to hepatitis C, not least because of what had gone wrong for so many patients in terms of the way in which they were tested and told of their HIV diagnosis?
No, I think all my colleagues, I wasn't making this as a recommendation, I was raising it for a discussion. And I said, what do we think in general as haemophilia directors, not only in Scotland but in England? What should be the process? Because this is something that might arise. And I think the general feeling was, well, we've been testing for LFTs and hepatitis B since 1970. We tell the patients, they will realize it's in their interest. It is, just trying to clarify what type of hepatitis we're testing for and what the appropriate treatments for that virus might be once it's identified.
Is it right to understand the kind of discussions that we've seen in the minutes, particularly the UK HCDO AIDS group minute, as identifying possibly three approaches to this question? One would be just do which may or may not have been Professor Bloom's view from the minutes, just add it to the range of tests, do the tests, and you don't need to say anything to the patient in advance. The second would be treat it like a LFT or hepatitis B test, but tell the patient, we're going to test you for hepatitis C as well now that there's a test. And then the third would be to discuss with them the implications of testing and invite them to agree to testing for hepatitis C, which would be more akin to the HIV counselling process. Is that broadly accurate?
Yeah, I think just looking at what haemophilia centres said they did across the 1990s, I think that was summarised very well when Dr. Charles Hay was asked as chairman of UK HCDO to outline the generally accepted procedure in 2011. And there was some discussion at that inquiry between Dr. Vivian Nathanson, who was wondering if there should have been a more AIDS-type approach, and Dr. Hay, who said robustly, no, we were pursuing the same treatment for hepatitis and telling patients about it. It didn't need that type of counselling, and he, I think, representing UK or English haemophilia centre directors, said there wasn't a comparison between them, and the basis that AIDS was thought in the late 1980s to be a very fatal and immediate disease, a big social stigma, and that was what influenced the need for pre-counselling and say, before testing, we realised that this is a very sensitive issue and requires a lot of counselling. Whereas hepatitis C, like hepatitis B, was on the basis that, well, finally we've got another hepatitis virus. It's important to test for this because we then know what the appropriate treatment would be. If you turn out to be a carrier, you will need information about emerging knowledge about what the prognosis is of hepatitis C disease and appropriate investigations. And as and when we think there's a treatment for hepatitis C, you will be referred to hepatologists for assessment for treatment. We thought that it was, so I think what I'm saying is my understanding that not only in Scotland, but across the UK, this was the general approach taken. And I think, just talking about Dr. Hay, because as you know, he and Dr. Preston were very involved in the early studies of liver biopsies, and it was Dr. Hay's study in 1985, which we recognized was an important contribution because it showed progression of disease in some patients who had repeated liver biopsies. And Dr. Hay and Dr. Preston, I think, were very involved in production of UK HCDO guidelines on testing for hepatitis C that came out, I think, from about this time period we're talking about, in circulations to haemophilia centre directors in the UK, and then I think a published guideline in 1995 about the management of hepatitis C. And reading these guidelines recently, I see no mention of having to do HIV-type counselling before them. You just did the test and got on with it.
Yes, you'll appreciate, Professor Lowe, that just because something's not in a UK HCDO guideline doesn't mean that it's not the appropriate or proper course. What was the actual course undertaken at Glasgow Royal Infirmary by you in terms of hepatitis C testing?
Well, I and my colleagues thought this was entirely reasonable. So at routine clinic reviews, we would go through the list of tests as all of it we're going to do, the routine blood tests, the biochemistry, and then say liver function test, hepatitis B, and we want to inform you that there's now a test for hepatitis C, and we think it's very important that we test for this as well, because, as I've said, there will be specific treatment available, and we want to know about it and keep you updated on what the progression of hepatitis C liver disease would be over the years, share that with you, and share appropriate decisions. And I don't recall any patient saying, no, I don't want to know about hepatitis C. If they did say, I mean, fair enough, if they did say, I don't want a hepatitis C test, we would say, okay, talk to you next time, but we do recommend it.
Which generation tests were used at Glasgow Royal Infirmary, and when was testing first introduced?
Oh dear, I have to go to my written statement here. Sorry. I think it started with an antibody test, and that became generally available in, I think, about 1991. It was approved across the UK, and then that, let me think. Yeah, so we started with the first antibody test, and we informed patients that if this were positive, it would mean they'd be exposed to the virus, but we needed to follow that up with future tests that would be developed as with hepatitis B, and these would be the antigen tests, and that would show the patient whether or not they were a carrier of the virus, because as with hepatitis B, a percentage of patients would have been exposed to it, they had a positive antibody, but the carriers had obviously the risk of progressive liver disease over the years, as with hepatitis B. So when the antigen tests arrived, that would be, I think, about 1992, 93. So we were generally using them. And at that time, if somebody had a positive antigen test, as per the UKHCO guidelines, it was then recommended that patients with positive antigen tests should be referred to hepatologists for management. And as I've said in my written statement, we then referred all these patients who turned out to be carriers of hepatitis C to the liver clinic, which was run by Dr. John Mackenzie initially, and then by Dr. Morris, who set up a very comprehensive hepatitis C service from 1996. And in the meantime, we always gave patients the current information leaflets, either by the British Liver Trust or the Hemophilia Society, which explained all the different types of hepatitis, what the tests were, what they meant, and these were regularly updated. And so at the end of a clinic, we'd say, this is the current information for you to read, and if you have any questions, do come back and we'll try and answer them.
So is it your recollection that the patients who were tested, both with the first generation and the next generation tests, for both tests, you spoke to them in advance about hepatitis C testing?
Yes, that's my recollection.
And would those discussions, or the fact of it having been mentioned to the patient and the patient having agreed, would that be recorded in the patient's records?
Yes, so you would put in the case records, hepatitis C discussed with patient and test performed, and then in your letter to the general practitioner, it would be normal practice to include that and say the patient has been tested for hepatitis C, and depending when the dictation was done, inform the general practitioner of the result.
And was the testing, both generation testing, undertaken by Dr. Follett again at Ruckhill?
Yes, that's right. So as with the HIV testing, it was the regional virus laboratory. I think Dr. Follett initially, and then I think he was succeeded around about the mid-1990s, but it was always the regional laboratory that did all the hepatitis testing way back from the 1970s with Hep B, then HIV, and then with Hep C.
Now, Glasgow Royal Infirmary had a large number of patients. In relation to the first generation testing, were all patients tested or only some? And if so, how did you identify which to test?
Well, we tested all patients. I mean, there would always be a small number of patients who'd not previously been exposed to blood products. But even we would say to them, we want to test you for hepatitis C because from, I think, about 1991, we were starting our previously untreated patient study, which I think you know about. We've published the results. And it was very important that we do baseline testing with the patient's consent because the whole point of the studies were to monitor them after first exposure to an SMBTS blood product, and then to establish after some period of treatment that the product was safe. In other words, there was no evidence of seroconversion to any of the pathogenic viruses, and that would include hepatitis C. So all of that would be explained to the patients before their first exposure to a product.
Now, the testing that you've described, as I understand your written and earlier evidence, that was undertaken at the routine clinic appointment. There wasn't any kind of special arrangement whereby patients were called in earlier. Is that correct?
Sorry, called in earlier.
So, in terms of the arrangements you made for testing your patients, as I understand the evidence you gave in writing into the Penrose inquiry, that was done at routine clinic appointment. So you didn't, as it were, the moment the test became available, write to all your patients and invite them to come in. As and when a patient came to the centre, the testing would then be undertaken. Is that correct?
Yes, so once we had the test available from Dr. Follett, we would routinely do it at the clinic. But I think what you're saying is, supposing somebody has not been at the clinic and then comes in for treatment, one would obviously want to do their routine blood tests, including hepatitis C, at that time. So whenever you first saw the patient when the test was available.
And then, as I also understand your evidence, that the results were given to the patient at their, and I'm talking about the patients coming regularly, at their next attendance, which might not be for many months. Is that right?
Yes, the initial tests were antibody tests, and that might be, we would routinely write to the general practitioner and give the result along with all the rest of the tests. We told patients that it might take some time for the test, and if they wanted, so we said, first of all, we're not sure, at the start of it, we said we don't know how long the tests are going to take, but we will inform you at your next visit, and if we think there is anything significant about it, we will let you know, or you're very welcome to ring and get your test result.
You referred to telling the GP the test result. Does that mean there may have been cases in which the GP found out that the patient was hepatitis C positive before the patient had been told?
I think I'm thinking particularly of patients at a distance, the patients who lived 100 miles from the centre. And I think if it was a remote patient, we would say to the GP, we may not see this patient for some time, and can you ask the patient if they could contact us to arrange another appointment?
So I don't think that quite answers the question. Were there cases, or might there have been cases, when the GP was told the hepatitis C result of the patient before the patient had been told?
No, I think when the result came, we would inform the patient. Sometimes the GP would have had the letter before the test was available, let me put it that way. And then if we got the positive result, we would write that extra information to the general practitioner, but I think we would also contact the patient at that time, particularly if they didn't have an appointment to come back in the near future. So we didn't leave it for a long time.
Were patients asked to agree to give their consent to their hepatitis C status being notified to their general practitioner?
I think all tests that we conducted, we said, right, we will include the results of these tests in the letter that we send to your general practitioner. The only exception to that was, as I think we were talking about yesterday, when we had the HIV tests, and some patients initially discussing with Dr. Forbes, when he and Dr. Wilkie were counselling, he said there are several patients who really didn't want the results to be put in a letter to the general practitioner, at least not at that time. So apart from that, all results were shared with the general practitioner, as would be normal medical practice.
How long do you think the process of testing your existing cohort of patients in the early 90s took? Was it something that effectively took place over 2 or 3 years, or something that was concluded swiftly?
So the testing process?
Yes.
We added it to the routine test, so it was done on every patient who either came up to the outpatient clinic or who was admitted. And then we had a system that if patients were not attending for review, if there had been a period of time, we had a standard letter that was written to the patient, copied to the general practitioner, saying you've not attended and it's now been X months, and we think it's important that you come because we want to keep you and your blood tests under review. So that was standard practice. And could I say that at about this time, 1991, when the test became available, we were very keen to see the patients because we were starting a series of clinical efficacy and safety trials of the new SNBTS products. This was the high purity products. And I think we've sent you documentation about the evolution of these studies. And we're very keen to get all patients seen at the unit, given information sheets about the studies we were going to do, and ask them to read them and give a written signed consent to participation in these studies, so that they could. This would be sorted out before we had to give them their first treatment with the new high purity SNBTS products, which were replacing from about 1991 to 92 the Z8 products, which, although virally inactivated, were intermediate purity. So we're very keen to have patients signed up to this. And these information sheets would say, to ensure the safety of these products, we want to make sure that you're tested for all tests for hepatitis have been performed before we start these studies.
Typically, with a patient who has tested positive for hepatitis C in 91, 92, what kind of information did you tell the patient on informing them of their diagnosis?
So we would say that this is the virus, which we think is probably because of what we previously called non-A, non-B hepatitis. In other words, it's sometimes been symptomatic in the past. It may have given you jaundice or other symptoms. And then a percentage of our patients, as in all the centres, quite a high percentage of patients have intermittent or persistent, slightly elevated liver function tests, and that's what we call non-A, non-B hepatitis. And we said to patients that this will, I think, clarify the cause of these abnormal liver function tests that we've been seeing. And if you're hepatitis C positive, particularly when it came to the antigen test, that means you're a carrier, and that is by far the most likely explanation of any raised liver function tests you've had in the past. If patients are repeatedly hepatitis C negative, you then have to consider some other cause of the liver function test elevation. But the hepatitis C testing would very much clarify that you were a carrier of the virus if you had a positive antigen test, and that would mean that you needed follow-up by a hepatologist and careful monitoring of your liver disease.
Okay. What did you tell patients, again, typically in the early 1990s, about prognosis and the possibility of developing, in what was known by then at least to be a progressive condition, serious liver disease?
Okay, so when I became a consultant at the end of 1985, and I think I've mentioned that in my written statement. I sat down with Dr. Forbes and we reviewed all the policies, and as the two consultants at the clinic now, what should we be saying to patients about non-A, non-B hepatitis? So first of all, because the study I briefly mentioned at the start of yesterday's session, Dr. Stephen, the consultant rheumatologist on the unit, had been reviewing all the patients at the Haemophilia clinic, both for their arthritis, but also he'd been assembling all the information over the years about abnormal liver function tests, etc. And he'd also been examining all the patients clinically for any clinical evidence of liver disease, not only jaundice, but enlargement of the liver and spleen. And he wrote up two papers in 1986, which I think I mentioned yesterday. One is the detailed survey of arthritis in all our patients, and the other was a summary of the liver abnormalities in terms of liver function tests, previous tests for hepatitis B, etc. So we had quite good information generally. So what we would say to the patients is we've now completed the study, and a high percentage of our patients have intermittent or chronic abnormalities of liver function tests. The significance of these in 1985 was that we had quite a good estimate of what the percentage risk was over the next number of years of a patient with non-A, non-B hepatitis progressing to clinical liver disease, that is cirrhosis. And as I think my evidence to the Penrose inquiry said, and I repeat for this inquiry, I would give and Dr. Forbes would give our best estimate from the current aggregate data. And this was based on the Hay et al. 1985 liver biopsy paper and the Aladort paper the same year in America. And putting all that evidence together, we could give a fairly definite estimate that 13 to 15% of patients who had biopsies showed evidence of cirrhosis or, in general, serious liver disease. So we'd give them some idea about what the risk of that would be over the years, and we would refine that over the years. So we would give them an honest estimate of what we thought the risk of liver disease was. But the other thing I think we said from 1985 was that the study we've done by Dr. Stephen, all our patients that have attended the clinic have had an examination over the last 5 years, and in none of them is there any clinical evidence of liver disease. But against that, we have to predict the future, and we have to monitor you carefully with clinical examination for liver disease. That's every routine visit. Keep testing and then from the early 90s, add on to that hepatitis C, and this is what we will now be judging, the decision to refer to a hepatologist and giving them the information about the connection between hepatitis C and how that built upon the previous information that we and other centres had on non-A, non-B hepatitis. And I think the phrase I used, and it's in the transcript of the Penrose inquiry, was something like, this is going to be a long journey. We can't answer all your questions now, but you and I and you and my colleagues are going to be sitting here year by year just giving you the information about how this is progressing. The more we know about hepatitis C, the more information we'll be able to give you, including what you should do in terms of alcohol use, lifestyle changes, and in due course, if we think if we have evidence that you become a carrier of this, we will get you straight to a hepatologist, and they will have specialist follow-up, and they will keep you fully informed about not only the development of any disease, but what investigations should be done and what treatment should be given. And that, as you know, would start with interferon.
Do you think it's possible that you may have, with some at least of your patients in the early 90s, telling them about hepatitis C, underplayed the seriousness of it, or told them that it wasn't really anything that they needed to worry about?
No, I don't think so. I think what we were talking about yesterday was the evolution of knowledge over, say, 1975 to 1985, before I became a consultant, where we were really quite uncertain, and we've had that discussion. But I think definitely from 1985, I don't think Dr. Forbes or I or Dr. Walker or any of the doctors doing the clinic would underestimate it. We'd say, these are the figures, and we know they might be frightening, but we can't predict. Will you be one of the 15% who in 5 or 10 years' time is starting to get symptoms of serious liver disease? No, but we can assure you we will keep you up to date, do all the monitoring that we can, and as soon as we think you need hepatological treatment, we will make sure you get that.
Can I ask you to look at one paragraph in your witness statement? It's WITN 3496013, Seamus, and it's page 69. Paragraph 30.12, you refer to having had 3 or 4 patients who developed cirrhosis, the majority of whom had either hepatitis B or heavy alcohol use or both, and then refer to it being about 1987 when you saw the first patient who had non-A, non-B hepatitis without heavy alcohol use. To what extent were you inclined in your treatment of patients with liver disease to assume that problems were due to alcohol consumption as opposed to the consequences of a transfusion-transmitted infection?
I don't think we ever made any such assumption. So what I said there is that, so I'm trying to think about the time scale here. So before 1987, my recollection was that out of our 100 or more patients, we only had 3 or 4 patients who developed cirrhosis, and there was a ready explanation. These patients were the small number of patients who had been hepatitis B carriers for many years, or heavy alcohol use, or both. So, you know, that it wasn't until then, 1987, that Dr. Forbes and I saw the first patient with the first clinical evidence of early cirrhosis, and there was no history of alcohol use, no evidence of hepatitis B. So that was the first time we saw a patient getting clinical evidence of serious liver disease from non-A, non-B hepatitis, and as I've said, that number of patients gradually increased over the next decade or two.
But why would you assume in a patient who you knew had been treated with blood products for many years that their signs of early cirrhosis or whatever it might have been was attributable to alcohol use or abuse rather than non-A, non-B hepatitis?
I don't think we excluded non-A, non-B hepatitis because we knew about non-A hepatitis. But if you had a patient who had cirrhosis, then in Glasgow, by far the commonest cause was a heavy alcohol use. But if you had blood transfusion, that was certainly going to be another factor. And then, as I say, the few patients we saw had hepatitis B, and that was known by that time to be a definite and very important cause of cirrhosis.
As treatments became available, so that can come down, Seamus. As treatments became available in the 1990s, in particular interferon, and then obviously ribavirin, pegylated interferon, and so on, what role, if any, did you have in arranging for your patients to receive those treatments?
Well, before interferon and subsequent drugs were even licensed for that treatment, Dr. Forbes and I had discussions, right through the 1980s. We had 2 very good gastroenterology colleagues, Dr. Russell and Dr. Mackenzie, And we regularly spoke to them about non-A, non-B hepatitis, particularly around the time I became a consultant when we had Dr. Stevens' study. And we reviewed it with them and said, well, what should we be doing? Do you want every patient with abnormal liver function tests referred to you? And we said, well, we're probably going to not be of much help. You could do liver scans, but they're insensitive and they don't tell you much and don't indicate any particular treatment. There's no effective treatment. Dr. Sherlock in London and colleagues had shown that steroids were ineffective. There was nothing apart from advice to minimize alcohol, which was a cofactor in any type of viral hepatitis for its progression. And Dr. Forbes and Dr. Russell and Dr. McKenzie said, there's no point in doing these biopsies. We know that there's a high risk of bleeding if you do a liver biopsy on a hemophiliac, even though they have treatment. And they were quite skeptical about these liver biopsy results. They said, if people have done studies on livers at post-mortem and cirrhosis is a knobbly liver, and he said it depends which bit you hit with the needle. And it's a bit hit and miss as regards estimating what the disease is, and they never recommended it. So they said, if a patient develops clinical liver disease, or if a treatment becomes available, or if we get more sophisticated means of investigation of the liver, by all means, but we don't think there's anything else you can do. But by the time we had hepatitis C, they were getting very interested in it, and particularly agreed that when the hepatitis C antigen test came in, they should start referring it regardless of any clinical evidence of liver disease or what the liver function tests were like, because as Dr. Preston says in his studies and his UK HCDO guidelines, in the biopsy studies, there's no relationship between the patient's pattern of liver function tests and the degree of what you see at biopsy. So they're very keen to see the patients, but as I think I said in my statement, that was quite a number to see. So we started referring every patient with hepatitis C antigen to Dr. McKenzie, and he eventually came to see me. That's lovely, Gordon. I'd like to see them all immediately. But the problem is that in Glasgow, like many other cities, there's a huge intravenous drug use problem. So I'm now getting flooded not only with your 100 or so patients with haemophilia, but a lot of patients referred by the general practitioners who are drug users who've got hepatitis C. So that was when Dr. McKenzie and I campaigned very vigorously with the managers to get a new specific post in hepatology with its number one priority being the patients with haemophilia, because my argument to the managers were, these are not the drug users or the alcoholics, these are the people who have got their disease through NHS treatment. They must come first. And they agreed, and they appointed John McKenzie, and he went and trained for 3 months in a specialist centre, and then came back and set up a service. And the joint clinic we established was in the Haemophilia Centre. It wasn't the routine clinic day. We had a specific clinic day, and all the patients with positive hepatitis C antigen tests were booked in, and Dr. John Morris, and he had a hepatitis C sister, Sister Nielsen. They were a very good team. So they would see the patients together, and also with either our haemophilia sister or the haemophilia staff nurse. So they would all have a very long meeting with the patient, partner, whoever else they wanted to come, and start the very intensive education about hepatitis C, including the treatment options, and at that time, interferon, I think, was being licensed and becoming available. That could only be prescribed by designated consultants in Glasgow, as in most places. It couldn't be prescribed by a haemophilia doctor or a GP. It had to be either infectious diseases consultants or hepatologist consultants. So they arranged as rapidly as possible the antiviral treatment, starting with the interferon, and then over the years as that progressed to double or triple therapy. They provided a very good service, and they gave written statements on their combined haemophilia liver clinic to the Penrose Inquiry, and I'm sure these are available to yourselves as
yes,
well.
the question, Professor Lowe, I think you may have answered it, but just to check, was We have access to those statements. Is what, if any, involvement you had in either prescribing interferon or monitoring the side effects of interferon? Was that effectively dealt with by Dr. Mackenzie, Dr. Morris, and the Hepatitis C sister, rather than by you and your colleagues in the Haemophilia Centre, is the question?
No, it was always joint management. So our patients with haemophilia who are hepatitis C carriers, we had to have joint care between the two departments, as we had set up 10 years previously for the patients who are HIV positive. So our haemophilia sister and staff nurse and ourselves, we rapidly learned all the details about the treatment, and we tried to make it as easy for the patients as we could, so that when they attended the clinic, they would have all the investigations done, both for haemophilia and for the hepatitis. And then after a few years, because of the increasing load of patients with hepatitis C, Dr. Morris and Sister Nielsen moved to the outpatient department at the other side of the hospital, and all the patients were seen there. But again, one of our haemophilia nurses would go over there, so we always had joint management. And then a lot of the monitoring, particularly of the double and triple therapy, required regular laboratory tests. So our sister and staff nurse in the haemophilia unit rapidly got together with the pharmacist who was controlling all these anti-hepatitis treatments, what tests were needed when, and we tried to make it as simple as possible for the patients, that we would try and do as many of these tests at the appropriate time and send them off for monitoring of interferon at the same time as we were treating them for haemophilia. So it was a highly organized liaison service.
Did your patients at the time of undergoing their interferon treatment have access to psychological support?
Yes, either we or the Dr. Morrison colleagues could refer patients for psychological support, and the route of contact had actually started with the HIV patients. So quite a good psychological support was set up at the Brownlee Centre, which was where the infectious diseases department had moved from Rock Hill about 1996. And that was not only for HIV, but for hepatitis C. And they had psychologists there, and I think the lead was a Dr. Roger Wong, whom we got to know quite well, because he had been involved with our patients with HIV infection. So there's an established route of referral.
I want to ask you now about a separate topic, Professor Lowe, and that's the question of post-mortems and post-mortem tissue and samples. Do you have any knowledge yourself, direct knowledge yourself, of circumstances in which post-mortems were undertaken on bleeding disorder patients?
I think there are very few. So when I came to Royal Infirmary in the 1970s, like in most hospitals, post-mortem autopsies were very routine, but then they rapidly, after the introduction of lots of testing, including scans, etc., those diminished, being done routinely. So I cannot remember from, certainly by the time I became a consultant, any of our patients attending any post-mortem of any patient with haemophilia.
Okay. And do you know anything about what tissue or other samples from deceased patients might have been held within the Royal Infirmary or any of the other Glasgow hospitals?
What post-mortems were done, and I can't remember any patient with haemophilia having one, I think the procedure was that the pathologist would do the autopsy and then select what tissue samples should be stored. I think Professor Ludlam covered this last week. It would be the same procedure as in Edinburgh Royal Infirmary, but you would have to ask the pathologist for details about what studies were done and how long they kept the samples.
ask you next a little about research. You've touched on, or we've touched on it already to some extent. Could we start by having NHBT 5094_043, please, Shomik? So this is a 1986 publication in the Scottish Medical Journal, Liver Dysfunction and Haemophilia. You are one of the named co-authors, along with Dr. Stephen and Dr. Sturrock, who you've already mentioned, Dr. Follett and Dr. Forbes. I'm not going to ask you to look at it in any great detail, but we can see from the summary, liver function studied in 139 of 291 haemophiliacs. And then if we go, I think, to the bottom half of that page, please, Shomik. Right-hand column, last few lines, we can see it says, we've examined the current prevalence of liver abnormalities in the haemophiliac population of the west of Scotland and reviewed the liver function of 57 patients prospectively for 5 years. And then it says, in addition, we have, and if we go over the page, to the top of the next page, we could zoom in a bit closer, thank you. Carried out immunological tests and related the results to those of liver function to examine the possible relevance of immune factors in haemophiliac liver dysfunction. And then we can see under the heading patients and methods, 139 out of 291 patients known to the Regional Haemophilia Centre at Glasgow Royal Infirmary and the Royal Hospital for Sick Children were seen and examined by a single clinician as part of a study on the prevalence, severity and pathogenesis of haemophilic arthritis. And then it goes on to talk about, if we look halfway down that column, information obtained about details of previous hepatitis or jaundice. Blood samples were tested for evidence of past or present hepatitis B infection, and then various liver function tests are then described. And then it refers to 57 patients being the subject of a more detailed analysis of liver function. And then if we look at the very bottom of the left-hand column, liver biopsies were not carried out, but post-mortem histology was available on patients who died of unrelated causes after the clinical study, and so on. What was the purpose of the research that's being described in this paper, Professor?
So, as I think I mentioned yesterday, following the symposium that Dr. Forbes held at the end of 1980, and I did mention to you at the start of yesterday's session, because you ended that by saying, but what were patients told about chronic liver disease at this time? So I recalled that in the early part of 1981 at the monthly research meeting of the department, Dr. Forbes and Dr. Sturrock, the consultant rheumatologist, they wanted to study 2 of these unsolved problems in the population of patients attending our review clinic, liver disease and arthritis. So Dr. Stevens' main topic for his MD thesis was a 5-year study of arthritis. So all the that's a separate paper, was published at the same time as this one on liver disease. And that was monitoring the patient's joints clinically and radiologically and looking at relationship to treatment, because as you know, the aim at this time was to see which patients in particular might benefit from home treatment to prevent progression of arthritis. And they followed up particularly the patients who were on home treatment at that time. So Dr. Stephen would be the clinician mentioned in this method section. So he would go to all the haemophilia clinics. So the patients were seen not only by a haemophilia registrar, but by Dr. Stephen. And he'd say, right, I'm the senior registrar in rheumatology. I'm doing the study. I want to examine all your joints carefully. And we're also interested in looking at, in all our patients, the liver function tests that have been done over the years. And he would give them the update on what was known at that time, which is the question you asked me the other day. You know, what is liver disease? And he would say, well, we've been to this symposium, and we know it's an increasing problem. That's one of the reasons that we want to monitor not only your joints, but we want to keep an eye on your liver. So he would be not just looking at the joints, he would be looking at for enlargement of liver and spleen, which in fact never occurred. And
Sorry,
then when it comes
Professor, can I just stop you there and just ask you, so it was Dr. Stevens as a rheumatologist, you're saying, would be advising the patients about the risks of liver disease?
Well, the people who would be at the clinic would be Dr. Prentice or Dr. Forbes as the consultants who knew the patients. And then one of their registrars, who at that time I think would be Dr. Small and then Dr. Greer. And then they would be seen by Dr. Stephen. And he would say that as well as the joints, I'm collecting information about your liver disease.
Professor Lowe, you say he would say that. Were you actually present? Are you able to tell us from your own first-hand knowledge that he did say that? Or is this your hypothesis?
No, because I'm not doing any of these clinics. I'm off doing general medicine and thrombosis clinics during this period of time. But we got regular updates on the progress of the studies at the unit research meetings, everybody in the department, including me.
Do you know from your own knowledge, rather than what you might assume would be the case as a matter, for example, of good practice, whether the patients who were here being studied were informed and asked to consent to their involvement in these studies in all their aspects, not just the arthritic aspect, but in relation to the immune function studies and the 57 patients who were the subject of a more detailed analysis?
Well, I never attended these clinics that Dr. Stephen was doing it because I wasn't doing from 1980 to 1985. I wasn't at these clinics, but we got regular descriptions of the progress of the study at the research meetings.
And it
would be routine for patients to be informed about what treatment they were having. There were changes, as you know, at that time between some patients being put back onto cryoprecipitate, etc. Patients were kept fully up to date as far as I understand about their treatments and about their liver disease. They were being examined for liver disease.
Professor, the question is, and it may be that you're not able to answer it, which is fine. The question is, do you know from your own knowledge what the arrangements were in terms of seeking patients' consent to being part of a research program, rather than generally being kept up to date about their treatment and their progress, but actually being told they were going to be the subject of a study and asking their agreement? Do you have any direct knowledge of that whatsoever?
I think the only, this is writing up. It's really an epidemiological study. It's following all the tests that are routinely done at the clinic. So it's examination for arthritis. The tests are routine tests. The only difference, which I think they would, Dr. Stevens would tell them, that they wanted to take an extra teaspoon of blood at the blood sample for these immunological tests. And that was tests like rheumatoid factor, anti-nuclear factor, complement, things that rheumatologists do. And this was because one question they're asking is it all virus, or are there disturbances of the immune system which are relevant to liver disease and its progression? So that was the only kind of difference in the information collected from the routine assessment of the patient.
So are you saying, in terms of the ethos of the Royal Infirmary in the early 1980s, or first half of the 1980s when this work was being undertaken, that there was no need to tell the patients that they were being studied?
Well, I think there would be. I mean, the default in Royal Infirmary, which was a very research-orientated hospital, I mean, many patients from the clinics and patients admitted to the wards were asked to be involved in research studies. So it would be standard practice to submit to the Research Ethics Committee the study. And if they advise that written informed consent, as distinct from verbal express consent, should be obtained, they would do it. I think I never saw the information sheet, but it would say we do want to take one extra blood sample, which is not routine, and that would be the immunological test study.
So what was your role in this study?
Only reviewing the paper, because I had no involvement in it, but at the end of 1985, when Dr. Stephen wrote this paper, I become a consultant, and as with many of the other studies, I was invited to give it a critical review and add any extra information to the paper. So I'm an author of the paper because I critically reviewed the paper, but I was not involved at the coalface.
Could we just have the paper up again, Seamus? NHBT 5094_043 and go to page 5. And could we look at the bottom half of the page? So the acknowledgement, Professor Lowe reads this. We would like to thank Dr. Willoughby, formerly of the Royal Hospital for Sick Children, Glasgow, for permission to study his patients. What was the basis for asking the clinician rather than the parent for permission to study children?
Well, I didn't know until I read the paper that the study also involved Dr. Willoughby's patients at the York Hill Hospital, but I see that Dr. Pettigrew is one of the authors. So it would be Dr. Pettigrew and Dr. Willoughby who would be explaining to the children and their parents that the study is being performed and obtaining their consent, I assume. Is that what you're asking about York Hill?
Well, it's bearing in mind that your involvement at least extended to looking at and critically analysing the paper. It was the particular text written there that had caught my attention, Professor, that I was inviting your observations on. But we'll move to a second piece of research, which is the research about immune function initiated by Dr. Forbes. We'll do it perhaps by reference to the published article, PRSE 0001121, please, Seamus. So we can see this is published in the British Medical Journal in October of 1983. Immunological abnormalities in haemophilia, are they caused by American factor VIII concentrate? And if we just look at the text, said abstract, Scottish patients with haemophilia, most of whom received no factor VIII concentrates for over 2 years, were found to have immunological abnormalities similar to those in their American counterparts, and then various details given. If we go back to the text, Seamus, we can see under the heading methods, it talks about patients with severe haemophilia A being selected, and then there is detail of the testing that was undertaken. And if we just go over to page 2, please, Seamus. Bottom of page 2, last paragraph on the right-hand side. It says, our results argue against a disease vector that's specific to American blood products. In terms of lymphocyte abnormalities, Scottish patients with haemophilia yield results that are consistent with those seen in AIDS and in acute viral infection. Whether these abnormalities in the T-cell ratios and in the response to concanavalin A are sufficient to render the patients immunodeficient and therefore possibly in a prodromal stage of AIDS will become apparent as the patients are followed up clinically. And then we can see on the next page just the date. If we zoom in on the top half of the page, Seamus, beneath the various references, we can see accepted 25th of August 1983. So this is a paper submitted to the BMJ or accepted by the BMJ in August of 1983. What was your involvement in it, first of all, Professor? Because we see you again as one of the authors.
So it's the same thing. It's critical review. So I remember Dr. Frobel presenting this paper at the monthly unit research meetings. And as I think I've said in my written statement, by that time, as part of preparation for writing up my own MD thesis, I'd done a course in medical statistics and became quite proficient in that. So as I said in my statement, I was quite often sought out as the kind of statistician on the unit, as it were, at least the clinical one, to critically review the statistical test performed and what it told you about the results, not in terms of the discussion about the clinical implications, but just did the data as presented, could you make a conclusion about this being carefully analyzed? So I think in return for this statistical comment, they put my name very kindly on the paper.
Do you know?
Sorry.
Okay. Do you know when in 1983 this study commenced?
I think it would be sometime in 1982, but I wasn't directly involved.
Was it your understanding, or is it your understanding now, that the trigger for this study was the reports from the States of AIDS in haemophiliac patients?
Oh, I think very much so. That was definitely the background. I think I read some of the... I told you I subscribed to The Lancet, so that was very much the British journal which was commenting on it. And I remember Dr. Forbes, again, presenting at the research meeting, saying, this is Dr. Frobel, and she and Dr. Maddock are going to be doing these studies because we really want to know, if these lymphocyte abnormalities are present in our population of patients with haemophilia. What does it mean? It may be a virus, but the other theory, and I think last week Professor Ludlam gave you pretty detailed information about the thoughts at the time and why they were doing very similar studies in Edinburgh. So I won't go into any detail of that.
Were the 19 Glasgow Royal Infirmary patients who were involved in this study told that their immune functions were being studied because of the risks of, or possible risks of AIDS?
Well, I think Dr. Forbes and Dr. Maddock, who were seeing these patients at the clinic, I would expect them to explain. I think that it was fairly well known in general amongst patients with haemophilia, and it was the Haemophilia Society was issuing information. I think there was concern, but again, I wasn't present. This would be the routine haemophilia clinic, and when Dr. Stephen was doing all the immunological aspects of liver disease tests, Dr. Maddock would be saying, well, in a subset of these patients, he would say to them, we want to do these tests of your lymphocytes to see if there is any similarity to what's been reported in patients with haemophilia in America, which might be of importance to your treatment.
So you don't know as a matter of fact what was said to patients, but you would agree as a matter of principle that the patients involved should have been told of their prospective involvement? Oh,
absolutely. So just as I expect that Dr. Stephen would explain why he wanted to do additional tests that might explain the emerging problem of chronic liver disease, Dr. Maddock and Dr. Forbes would do the same thing.
If we just have the document back on screen, please, PRSE 301121, and go to page 2, Shomek, bottom of the page. Now, if we just look again at the last paragraph, this is saying, isn't it, that the Scottish patients studied is showing results consistent with results seen in those with AIDS. And it's recognising in the last sentence the possibility that these patients may be in a prodromal stage of AIDS. Do you know whether the patients themselves were told that that was what their results showed?
Well, I wasn't at the clinic, but I do remember Dr. Forbes and I having a discussion with the chairman of the local Hemophilia Society, and he was regularly reporting back to Dr. Forbes, feedback from the patients, etc. And he said, oh, we're very interested in these studies. And I think, in fact, they may have been supporting these studies financially with a grant from the Scottish Haemophilia Society, and saying, well, we know it's all trying to work out if there will be an increased risk of AIDS, whatever its cause, and we're very keen to support this work being done. But that's the only direct memory I have of patients talking about it and saying they knew what it was about and they were very supportive.
Do you agree, as a matter of principle, as you weren't involved in the actual arrangements, but as a matter of principle, those of the 19 patients whose results were consistent with those seen in AIDS and who could possibly be in a prodromal state of AIDS should have been told that at the time, as a matter of principle?
I would have thought so. I think Dr. Forbes was asked about this at the Penrose inquiry, and he said the problem was we didn't really know what these meant. We knew there was a change, but as it says in the discussion there, whether that will be a virus or just an effect of having lots of factor VIII was very uncertain.
Do you know, again, as a matter of fact, Professor, whether the outcome of this study, which would have been known to Dr. Forbes by August of 1983, led to any change of approach to the treatment that was provided and the treatment policies applied at the Royal Infirmary Haemophilia Centre?
I think, again, I would quote what Dr. Forbes said at the Penrose inquiry, and I think he said that, yeah, we looked at the treatment we were giving the patient, and he said that there was very little use by this time of the American commercial concentrates. Scotland was self-sufficient now in the factor VIII concentrates. Because of the concern about age, some of these patients some of the patients had been offered to revert to treatment with cryoprecipitate rather than concentrate, just to reduce the number of donors. So I think all of that was in his mind generally. Whether he spoke to specific patients about their treatments in addition to the general policy, I do not know.
Okay. Is the answer to my question, which is not about what Dr. Forbes said to the Penrose inquiry, but is about your own knowledge, that you don't know from your own knowledge whether this led to any change of approach within the Royal Infirmary?
No, I didn't.
And then one final study, PRSE 303671. Please, Seamus. So if we look at the article on the bottom half of the page, please, Seamus, compared cell-mediated immunity and haemophilia in the absence of infection with HIV. Again, you're there as a co-author along with Dr. Maddock, Dr. Frobel, Dr. Follett and Dr. Forbes and others. And it refers to skin tests, amongst other matters. And we can see from patients and methods, bottom of the page, it's a study of 29 patients with clinically severe haemophilia, attending the Glasgow Haemophilia Centre. If we go over the page, including 12 of 15 patients known to be seropositive for antibody to HIV, etc. All patients were examined for features of disease related to HIV. And then if we just look at the conclusion, third page, please, Seamus. If we just zoom in on the top half of the page. Thank you. So we can see the conclusion suggests that cell-mediated immunity is decreased in patients with severe haemophilia treated with factor VIII concentrate. This is related to the amount of factor VIII used. Whether this abnormality is related to risk of infection with HIV or its sequelae or both is not yet known. Now, again, what was your involvement with this study, Professor?
So, no direct involved. I became a consultant and was doing the clinic from about the end of December. I was aware that the study was going on. My understanding was that Dr. Maddock, who performed the study, was obtaining permission from the patients to do this study and explaining that we wanted to know whether these changes in the lymphocyte counts were confined to patients who they now knew had HIV infection, or were they to be seen in the HIV negative patients, in which case one needed to look for another explanation. And the best way to do that was this DNCB test, which was a skin test, and patients would have to give consent to this because it wasn't a routine test at that time. And the finding of it, as you can see, is that cell-mediated immunity is decreased in patients with severe hemophilia treated with factor VIII concentrate. This is related to the amount of factor VIII used in the absence of HIV infection. So they needed to do further studies to find out what the significance was. And as you know from Professor Ludlam last week, they were very involved in Edinburgh in doing similar studies to find out what was the cause. And Professor Ludlam discussed that extensively with you. Again, I was only asked to comment on the methodology, the statistical significance, etc. And Dr. Maddock continued this work for a few years, looking at different aspects that might lead to further explanation.
Okay. Were you involved at all with the process of either obtaining patients' consent to participation or in what might have been told to patients about the results of the testing?
No, I don't think so. Dr. Burrs was there at the time, and he and Dr. Maddock knew much more about the immunological aspects and the interpretation than I did.
Final question on the topic of research. You may, I think it's clear from your answers, you listened to Professor Ludlam's evidence last week. I asked him about research on the sexual contacts and household members of HIV-positive patients. And you may recall, I'm not going to put any of the documents up, but Professor Forbes, in his capacity as chair of the UK HCDO's AIDS group, had suggested or invited directors to participate in a survey of sexual contacts and household members, and you'll recall Dr. Jones expressed concern about ethical implications. Do you know whether at the Glasgow Royal Infirmary any such study was undertaken?
I think that Dr. Maddock and Dr. Forbes wrote a letter in the Lancet. Is that available to you?
I don't have the reference to hand. We may be able to obtain it, but we can read what's in the Lancet, Professor. So it's really, do you have any knowledge, particularly bearing in mind that you took up your post as consultant in late '85, and this was a study that was being mooted by Dr. Forbes within UK HCDO in the second half of 1985. Do you have any knowledge or recollection of whether such a survey or study was undertaken in the Royal Infirmary?
So this is a study of HIV positivity in sexual partners of the patients at the Royal Infirmary?
Yes, sexual partners and household contacts.
Well, it was part of the management of these patients that they were advised to discuss with their sexual partners, and then they would be counselled, particularly by Dr. Wilkie or by consultants at the sexually transmitted diseases who were much involved in the Glasgow AIDS programme, given information and asked if they wanted to be tested. And I think a report and a letter on the frequency of, oh yes, and at the same time there was concern about household contacts, non-sexual household contacts. So I think these were done as part of the clinical management, and I think that Dr. Maddock wrote a letter on the numbers of such patients, which basically was, of the numbers tested to the time, there had been no evidence of transmission of HIV to sexual partners or to household contacts. I think it was the Lancet, I may be wrong.
I'm going to ask you to deal very briefly with the issue of VCJD, Professor, because we have a significant amount of documentation about it. But there are two documents I want to ask you to look at. The first is at GGCL 40152_001, please, Shona. So this is a letter dated the 25th of October 2002. It's from you to Dr. Armstrong, Chief Medical Officer, and you. The heading is SMBTS Factor 8 and Factor 9 VCJD notification strategy. Further to our letter the 25th of September, to date we've had no reply from yourself or from the Banner Committee. It's now 8 months since haemophilia directors in Scotland and Northern Ireland, having been informed of the relevant batches of SMBTS coagulation factor concentrates, to which a donor who subsequently died of VCJD contributed, prepared information sheets for haemophiliacs in Scotland who were potential recipients. In the absence of any comment from the Banner Committee, haemophilia directors in Scotland and Northern Ireland met at the UK HCDO annual meeting in Liverpool on 10 October 2002 and agreed to proceed to circulate their patients with information sheets we prepared in February. And then you go on to say there's a proposal to discuss that at an annual meeting with the Haemophilia Society in November, and then send it to patients. Now, just pausing there, it would appear from this that there was some kind of delay in the notification process or the information sheets being sent out, and you were writing to express concern to the Chief Medical Officer at the absence of any response to the proposals of haemophilia directors in Scotland and Northern Ireland to undertake this exercise. Is that correct?
That's correct.
Do you know what had caused the delay?
I think on your behalf, I spent some time trying to access the relevant documents back in September, and I've outlined for you the best information of the progression of this matter in my written statement. So very briefly, this was an incident of possible exposure of UK patients to VCJD, and this was notified by SMBTS when they discovered that a blood donor from previous years had been found to have evidence of VCJD at just found to have VCJD, and this applied to several of the SMBTS concentrates used for treatment between 87 and 89. So we had several discussions, which I've outlined at meetings of haemophilia directors, the coagulation working party in February, at which we involved SMBTS as well. And then in January, Professor Ludlam reported that he had written to the Banner Committee. Now, this was Sir Michael Banner's National UK Committee, which the government had asked to investigate any reports of this and what should happen to transfusion patients who had received these batches. Back in February, haemophilia directors and SMBTS thought, well, as with the previous outbreak from BPL a year ago involving patients in England, we should prepare press releases and information sheets for patients so we could inform them. The response we had from the Banner Committee clearly stated that patients should not be contacted until the panel had advised on their individual risks, and they asked all the haemophilia centres in Scotland for anonymous data on the numbers of vials of the relevant blood products being forwarded to the panel for consideration. And then also in June, we had the annual meeting of Scottish haemophilia directors, SMBTS directors, and Dr. Armstrong, who at that time was the Chief Medical Officer for Scotland. And we expressed our concerns to him about the delay. And we said there had been a very timely release by BPL and Haemophilia directors in the English episode a year ago, we had assumed that a fairly rapid information should be provided, and what was happening. Now, my recollection was that Dr. Armstrong was very understanding of the desires of SNBTS and Haemophilia Centre directors to get some action, and when could we release the information publicly and to our patients. And he agreed to raise the matter at the next meeting of the UK Chief Medical Officers. And I think what had happened in between 2001 and 2002 was that following the BPL outbreak, all the UK Chief Medical Officers in the 4 nations had got together and said, we don't think patients should be told because there's nothing you can do about, we don't know what the risk is, and we think that patients who had received these things in general shouldn't be told. Now, we thought poorly of that, but clearly this was Dr. Armstrong's position. He said, well, I want to discuss with the other UK Chief Medical Officers. So we gave him a list of questions at that time saying, look, these are our concerns, please share them. And then we kept getting no information until at this meeting in Liverpool that you discussed. We thought, well, look, it's now been several months. We've heard nothing from the Banner Committee. We think we should be open with our patients, both SNBTS as the providers and the haemophilia directors who are looking after their patients. And that was when I firstly consulted my Glasgow Infirmary medical director, and he said, yes, the Trust supports you in this action. And I sent this letter to Dr. Armstrong, and at the same time, I think Professor Ludlam had direct conversations with the Deputy Chief Medical Officer for Scotland, Dr. Keel, because Dr. Armstrong was on holiday. And we said, look, this is the kind of statement we think should be issued to the public and to patients. And then the response to both Professor Ludlam and myself from Dr. Raelene Keel was that her advice was that, yes, haemophilia directors should proceed to inform their patients and offer appropriate counselling, and thought that instead of statements from the Trust, which we had suggested, it would be better to have a national Scottish information release from the Scottish Health Department and SNBTS. So that was finally agreed of what these documents would be, and the letter was sent to patients on the 26th of November, and I've sent a copy of that letter as well as the press briefing we all sent it to all our patients, and the statement was issued on the 27th of November.
So is this right, Professor Lowe? Your understanding of the reason for the 8 or 9 months delay that elapsed between you and your colleagues indicating that you wanted to provide this notification to your patients and the notification going out in towards the end of 2002 was because of a central government and or Scottish concern or view that patients shouldn't be told. But once you wrote this letter that we've just been looking at, you got a response saying, well, go ahead anyway.
Well, we were frustrated about the Banner Committee's delay. Now, we understood that they wanted to make a risk assessment. They were considering a risk assessment which might be varied depending on how many vials the patients had received. But we never received any information about that. And when it got to the stage, we thought, this has been almost a year. We should really be sharing this information. And this was our level of frustration. I think you could ask the relevant departments of health or the Banner Committee, don't know if it's still going, about what was the reason for delay, but we thought that we should get on and tell the patients.
Thank you. So I note the time, and I'm going to move on to another topic. We can take a break now.
We'll take a break now until, 4:15.
Yes, or I wondered whether, I don't know, is Professor Lowe able to come back a little earlier than that, or...?
Well, it is a Friday, so we may want to finish earlier if we possibly can. So what about 4 o'clock? Would that give you long enough?
4 o'clock would give me long enough, Sir Brian.
4 o'clock.
Thank you, sir.